This is your discussion on acute coronary syndrome. So acute coronary syndrome or acute myocardial infarction. This is an emergent condition characterized by acute onset of myocardial ischemia. You highlight and remember the words emergent, and it is considered to be myocardial ischemia that results to myocardial death if definitive intervention do not occur promptly. Now it is synonymous with coronary occlusion, heart attack, and myocardial infarction. This syndrome is characterized by the sudden occlusion of a coronary artery. Because of that sudden occlusion of the coronary artery, there is cessation of blood flow. And because of the cessation of blood flow, there is abrupt and severe deprivation of oxygen. So take note of the term sudden occlusion leading towards cessation of blood flow, going towards deprivation of oxygen. These factors combined, it leads to your ischemia. Okay, brought about by the decrease of oxygen going towards the part of your heart. Now for the pathophysiology, note that your myocardial infarction could be caused by the change in the condition of plaques, okay, which can be a product of your coronary artery disease. Whenever there will be a change in the condition of the plaque, the platelet might be activated. Because of the activation of this platelet, there will be thrombus formation. Okay, once thrombus or clot is formed, the tendency of the clot is to block the blood flow, leading towards what you refer to as ischemia. There will be an ischemia on the tissue being supplied by the artery. Other than that, there will also be occurrence of vasospasms. So your vasospasm again is the sudden constriction or narrowing of your artery, leading towards decrease of oxygen supply. The decrease of oxygen supply would cause an increase of demand versus supply, hence leading towards your infarction. Okay? Now, your infarction is already your myocardial cell death. Before that part undergoes myocardial cell death or infarction, it first undergo ischemia. When ischemia is prolonged, there will be cellular injury. And after the cellular injury, there will be infarction. So again, the order is ischemia, injury, and infarction. Assessment findings. There are several assessment findings for this patient. The cardiovascular signs and symptoms would of course include chest pain, discomfort. This is not relieved by rest or nitroglycerin, unlike your angina. There will be occurrence of palpitations. Extra heart sounds and murmur may be present. There will be jugular vein distension. Your jugular vein distension is evident if there is already signs of heart failure. Okay, your jugular vein is more of right-sided heart failure. There will also be blood pressure changes. Initially, your myocardial infarction could be caused by hypertension. However, once the patient already had myocardial infarction, the tendency is for the patient to have decreased blood pressure. The decrease of the blood pressure is brought about by the decrease of the contractility of the heart. Because again, if you can recall, in myocardial infarction, there is a block on the artery. Because of the block on the artery, the tendency is for the decreased blood flow towards a part of your heart. Because of this decreased blood flow towards the part of your heart, there is decreased contractility of your heart, hence leading towards decreased blood pressure. Then you can have irregular pulses. Your irregular pulses may be a result of atrial fibrillation or any fibrillatory changes in your ECG. Respiratory signs and symptoms are oftentimes effects of your pulmonary congestion. Because of the impaired pumping mechanism of the heart, the tendency is for the blood to backflow from the left side of the heart, from the left ventricle to the left atrium, from the left atrium going back to your pulmonary, pulmonary organs, or your pulmonary area, resulting towards your pulmonary congestion, hence the respiratory signs and symptoms. Your patient may also have decreased urine output. Decreased urine output is brought about by the decreased blood flow going towards your kidney. Because of the decreased blood flow going towards your kidney is unable to filter the blood wastes, leading towards your decreased urinary output, oliguria or anuria. Okay, we refer to this one as your cardiogenic shock. Shock leading from your cardiac origin. Then, skin problems. You can have the skin problems including cool, clammy, diaphoretic, and pale appearance that is brought about by cardiogenic shock. That is also brought about by your sympathetic stimulation. Okay, take note that your patient, because of the decrease of blood pressure, will attempt to compensate by stimulating your sympathetic nervous system. Okay, with that stimulation, the tendency is for vasoconstriction to occur. Hence, your patient would have your pale appearance. Neurologic, your patient would have anxiety, restlessness, and lightheadedness. This is brought about by increase in your stimulation also of your sympanervous system. But despite the stimulation of your sympanervous system, there will be a decrease in contractility and cerebral oxygenation. Okay, decreased contractility and cerebral oxygenation. Psychological, your patient would have fear with feeling of impending doom or denial. Okay, the feeling of impending doom is a classic sign of your myocardial infarction. Denial in the sense that they tend to deny that they have a severe or life-threatening condition as a coping mechanism. A 12-lead ECG is considered vital for the diagnosis of myocardial infarction. So your 12-lead ECG is used to rule out myocardial infarction. It should be done within 10 minutes from the time of pain or arrival in the emergency room. So you have three prominent changes found in your myocardial infarction. One, T-wave inversion, which indicates ischemia. ST segment elevation, which indicates already injury, and then your abnormal Q wave would indicate your myocardial infarction or necrosis. Okay, so take note of the progression. First T wave, then ST segment elevation, then you would have your abnormal Q wave. Okay, this would signal again ischemia, injury, and infarction. Q waves would usually develop within 1 to 3 days. It's possible that your patient would have an abnormal Q wave, but the two other findings are normal. If that's the case, that the Q wave is present, however, there is no ST elevation and T wave inversion, that indicates that there is an old myocardial infarction and not an acute myocardial infarction. So it's possible that your patient might have had a heart attack and she was not able to notice it. Okay? Now, also one prominent finding in your acute MI is the significant decrease in the height of your R wave. Other than that, we have the term STEMI, ST segment elevation myocardial infarction. In this type of myocardial infarction, the ST segment are elevated into contiguous leads. When I say contiguous leads, these are leads who are sharing a common border. In other words, they are leads which share the same part of the heart or evaluate the same part of the heart. Example of your contiguous leads are shown on this slide. Those leads with the same color indicate that they are contiguous leads. So if there is an ECG abnormality, for example, in lead 2, lead 3, and then AVF, that would mean that there is a problem on a specific part of the heart because these are considered to be contiguous leads. Then you have your NSTEMI, N, non-ST segment elevation myocardial infarction. This happens if the biomarkers are increased but the ECG changes are not prominent. Again, the biomarkers are increased but the ECG changes are not prominent. Hence, it's referred to as NSTEMI, non-ST segment elevation myocardial infarction. Then we have the term echocardiogram. Your echocardiogram is used to evaluate your ventricular function. It is used to diagnose your myocardial infarction, especially when the ECG is considered to be non-diagnostic. Recall that your echocardiogram is also used to evaluate the ejection fraction of your patient. Then, we have the following laboratory test. As mentioned earlier, you have your cardiac biomarkers. Your cardiac biomarkers are increased in both STEMI and NSTEMI. The only difference again of NSTEMI is that there is no ECG changes. Now, let's talk about the cardiac biomarkers. So you have your CKMB, your troponin, and then your myoglobin. Take note that your CKMB would start to increase within 4 to 6 hours after the onset of chest pain. Peak within 24 hours. Then you have your troponin I, troponin T. Between the two, your troponin I is more specific for cardiac problems compared to troponin T. They are considered to be reliable and critical markers of myocardial injury. There are no other organs in the body that would release troponin I and T if ever damaged. It's specific to your heart. So it can be detected within 3 to 4 hours upon the onset of your myocardial infarction, and the peak is from 4 to 24 hours. It can remain elevated for 1 to 3 weeks. Then you have your myoglobin. Your myoglobin is found in cardiac and skeletal muscles. Take note, cardiac and skeletal muscles. Increase within 1 to 3 hours and peaks within 12 hours after the onset of symptoms. Since it is found in both cardiac and skeletal muscles, its increase is not very specific indication of myocardial infarction. It can be used to rule out for the presence of myocardial infarction, but it cannot directly diagnose your myocardial infarction because increase of myoglobin may also indicate damage to your skeletal muscles. The following are the goals for medical management. One is to minimize myocardial damage. This can be done by decreasing the heart's workload and increase the supply to the myocardium to limit the extension of your area of infarction. Second, to preserve myocardial function, and third, to prevent complications. Now, medical management. The common acronym that we need to remember for the management of your myocardial infarction is MONA. MONA stands for morphine, oxygen, nitroglycerin, and aspirin. Morphine. Your morphine is considered to be the drug of choice for myocardial infarction. Okay, as a drug of choice, its function is to reduce pain and anxiety experienced by your patient. With that, it can reduce the preload and afterload. It can also decrease the workload of the heart, which is your main problem in myocardial infarction. There is decrease in oxygen and increased workload. So, for morphine sulfate, your morphine sulfate would decrease the workload of the heart. Then, it monitor for responses and assess for hypotension and decreased respiratory rate because one complication of your morphine sulfate is neurodepression, okay, which can be manifested by your hypotension and decrease in your respiratory rate. Then, we have problems in oxygenation. That's why we give supplemental oxygen to your patient. Nitroglycerin is given as a vasodilator and your aspirin is given as an antiplatelet. Then you have your beta blockers for dysrhythmia. The beta blockers for dysrhythmia should be introduced within 24 hours of admission. Then we have the administration of heparin, particularly your low molecular weight heparin. Your low molecular weight heparin is considered to be a platelet inhibiting agent. So with the same purpose to prevent further clot formation. Then we have your emergent percutaneous coronary intervention. Okay, your emergent PCI is considered to be emergent because if the PCI would be delayed, it can aggravate the area of infarction. So when I say PCI, your PCI is an open occluded coronary artery in an acute MI that promotes reperfusion of that area deprived of oxygen. So one procedure under your PCI is your PTCA. PTCA is percutaneous transluminal coronary angioplasty. So we'll be discussing that procedure later on. Then you have your administration of thrombolytics and fibrinolytics. So when I say thrombolytics or fibrinolytics, your thrombolytics is capable of dissolving the clot. The purpose of dissolving the clot is to induce reperfusion, okay, or to facilitate the flow to the coronary artery, hence minimizing the size of infarct and preserve your ventricular function. Okay, it dissolves the clot, but it does not alter your atherosclerotic lesions. Examples of drugs under this category is your streptokinase. Indication. This is indicated for chest pain, which could not be relieved by nitroglycerin, especially if it is lasting for 20 minutes or more. Among those patients also with ST segment elevation in at least 2 contiguous leads. And then it should be less than 6 hours from the onset of pain. So take note for thrombolytics, the window period is 6 hours. Beyond 6 hours, your thrombolytics will be not of benefit to your patient. Absolute contraindication. Remember, your thrombolytics can dissolve your clot. Now, to dissolve the clot, the following are contraindicated for this procedure or for this drug administration. Any bleeding problems such as hemorrhagic stroke, such as your AVM or your adrenovenous malformation. Okay, your adrenovenous malformation could rupture resulting to bleeding, and then any recent major surgery or trauma because it can also lead to bleeding. If your patient has uncontrolled hypertension, it is also not possible to administer your thrombolytic because hypertension is a risk factor for stroke. Added to thrombolytic, you will have your hemorrhagic stroke. Then pregnancy. Your patient who is pregnant may be at risk also for bleeding, and also it crosses your barrier, which can lead to fetal complications. So nursing considerations. Because of the risk for bleeding, you need to minimize the number of puncture, avoid intramuscular injection. You need to collect the blood by the time that you're inserting the IV site in such a way that there will be only one puncture for the IV site and then the blood collection. Then you can start the IV line before the thrombolytic therapy is given, and you can designate one line to draw for blood samples and specimen. You are advised to avoid continual use of blood pressure cuff because it could also lead to bruising. Monitor also for the presence of acute dysrhythmia and hypotension. We also monitor for reperfusion or resolution of angina. That would indicate already that the area of the heart is already reperfused, and then resolution of your acute ST segment changes. You always watch out for the signs of bleeding. So that may include the decrease in your hemoglobin, decrease of hematocrit, decrease of blood pressure, increase of heart rate, because in bleeding, take note, your heart will try to compensate. Any oozing or bulging in the invasive procedure site, back pain, which may indicate internal organ bleeding, muscle weakness, changes in the levels of consciousness, and complaints of headache. Your changes in levels of consciousness and complaints of headache may be related to cerebral bleeding. Okay, so take note, your thrombolytics is a drug given to dissolve the clot. However, it has several contraindications and precautions because also of the risk for bleeding. Then the following are your continuing pharmacologic management. One is the administration of your aspirin, an antiplatelet. Then your beta blocker, your olols, and then your ACE inhibitors. Your ACE inhibitors again inhibits your angiotensin 2 and also prevents remodeling of your myocardial cells with the onset of heart failure. Okay, so take note, one function of your ACE inhibitor other than reducing your blood pressure is to prevent the remodeling of your myocardial cells, which is actually associated with the onset of your heart failure. Now, this is the procedure that we refer to as your PTCA. Okay, your PTCA is an example of a PCI. So the purpose of your PCI is to open occluded coronary artery in an acute MI and to promote reperfusion. So when I say reperfusion, you would want the blood flow to be restored again. So in PTCA, a balloon tip catheter is being used to open the blocked coronary vessels and to resolve your ischemia. Looking at the picture here, you can see that a balloon is being inserted on this side, and the purpose of the balloon is that by the time it will be inflated, it will open the blood vessel. It will expand the blood vessel, hence promoting your blood flow. Okay, so again, another purpose is to improve the blood flow within the coronary artery by compressing the atheroma. So your atheroma or your atherosclerosis are the deposits of your fatty substances. So surgical procedures. Okay, other than your PCI, we can have an open surgery. This one is referred to as coronary artery revascularization. So under your coronary artery revascularization, you have what you call your CABG or your coronary artery bypass graft. Look at the name, coronary artery bypass graft. With the name itself meaning the coronary artery. Okay, the coronary artery will be repaired through a bypass. Now, so in your coronary artery revascularization procedure, we are creating new routes for the narrowed and blocked arteries, which would allow sufficient blood flow to deliver the nutrients to the heart. If you would look at this procedure, okay, in this procedure, this is a single CABG. What happens is that a new route is created from this part of your aorta going to this part of your heart. That is to allow for the perfusion of a significant part of your heart. So in other words, if this is your blood vessel, demonstrated here with the red color, if there is a blockage on this part, the tendency for us is to make another bypass from another blood vessel going towards this part. Okay, that is to ensure that this part of the heart will be reperfused. Okay, that's why it's referred to as bypass. In other words, we are creating a bypass. Then we have the term cardiac rehabilitation and exercise. After a procedure, our main goal is to improve the quality of life of the patient. And improving the quality of life of the patient could be done using your cardiac rehabilitation and exercise. It is not possible for your patient just to have, okay, or for your patient to return immediately to normal functioning or functioning before the cardiac arrest if the patient will not undergo your cardiac rehabilitation and exercise. So the purpose is to improve cardiac function and assist the patient to return to normal. There are three phases for your cardiac rehabilitation. The phase 1 actually begins by the time atherosclerosis is diagnosed. It may be in the hospital setting or the outpatient setting. Your focus here is the essentials of self-care. Okay, your focus is essentials of self-care and not yet the behavioral changes for the reduction. So, among the things here that you would be teaching your patient will include signs and symptoms, wherein you need to go to the ER or call 911 if you're in the US setting, the medication regimen that needs to be given, the rest activity balance, and then follow-up appointments with the care provider. Then on the phase 2, this occurs by the time the patient is discharged. This means the patient would need to attend 3 sessions, okay, for 4 to 6 weeks, but may continue longer depending on his responses. Okay, so during this procedure, the patient is exposed to a set of healthcare professionals which will gradually expose him or her to series of exercises. Then phase 3, your phase 3 is focused on long-term outpatient management, focusing on maintaining cardiovascular stability and long-term conditioning. Okay, now there are several nursing diagnoses for this patient. One could be acute pain, then you can have your risk for decreased cardiac tissue perfusion, and then risk for imbalanced fluid volume. The risk diagnosis there may be evident if your patient would have atherosclerosis. But if your patient already have myocardial infarction, our best nursing diagnosis would be decreased cardiac tissue perfusion related to reduced coronary blood flow. Now, for acute pain, your nursing intervention will be to administer your MONA or your MONA. M is morphine, which decreases the preload afterload, hence decreasing the workload of your heart. Then oxygen, because remember, the main problem in your myocardial infarction is the decrease of oxygen going to a specific part of your heart. Then you have your N, nitroglycerin, which would cause vasodilation, hence promoting blood flow, and would also cause venous vasodilation, which would lead towards pulling of the blood to the peripheral aspect of the body, decreasing your preload. And then you have your aspirin, which prevents your clot formation. Then, for the risk for cardiac tissue perfusion or decreased cardiac tissue perfusion, you might want to educate your patient on bed or chair rest to help reduce myocardial oxygen consumption. If your patient is at risk for MI, you need to educate them that by the time that the chest pain that occur, they need to stop their activity and they need to be placed on complete bed rest. Now, risk for imbalanced fluid volume, then risk for ineffective peripheral tissue perfusion, anxiety, and then you have deficient knowledge about post-ACS self-care. So one thing that you can do is to reduce the anxiety experienced by your patient. Develop a trusting relationship, and then provide an honest and supportive manner. Okay, and then you need to allow verbalization of client's fear and concern. Your patient may not be saying it, but they will have signs of anxiety because of the feeling of impending doom related to your myocardial infarction. Okay, they have the fear that they will be dying because of the disease that they are experiencing. So planning and goals, so you need to ensure that the pain is relieved. You want to prevent further damage, so we have our patient on complete bed rest, oftentimes without bathroom privileges. So to maintain effective respiratory function, your patient needs to be on high back rest so that diaphragmatic excursion will be maximized. Then maintenance of adequate tissue perfusion, oxygen would help. Your PCI, PTCA would help. Reduce anxiety by your presence and adherence to self-care program and early recognition of complications, which is addressed by your cardiac rehabilitation. This slide is a comparison of angina and myocardial infarction. If you can see, angina is characterized by chest pain that can be relieved by rest or nitrates. On the other hand, your myocardial infarction could not be relieved by nitroglycerin. Then, your patient would have pale, clammy skin, and your patient may have tachycardia or hypertension in your angina. However, in your MI, the tendency is for your patient to become hypotensive once MI has already started. And then your patient may have gastrointestinal related symptoms in MI. By comparing them through ECG, it can be seen that in angina, there is T-wave inversion and ST segment depression. Okay, this arrhythmia here may be temporary. Then, in your myocardial infarction, there may or may not be ST segment elevation. Q wave appears as a sign of infarction, which indicates that there is already an old myocardial infarction or myocardial infarction which have been there for 1 to 3 days. Then there will be elevation of troponin. And then dysrhythmia is more persistent compared to your angina. This will be the end of your discussion for acute coronary syndrome. So these slides are adapted and revised from the PowerPoint presentation of Professor Jest. Thank you very much for your kind attention.